Well, hello and welcome everyone to Measuring the Impact of AI in Healthcare, a virtual summit produced by Health Impact Live and Answers Media Network. I'm Carol Flag of Answers Media Network, and this event would not be possible without support from our sponsors, Inovalon, Avasure, and Nitera. This event has been approved by Chime for up to 4 non-Chime CEUs towards these certification programs: CHCIO, CHISL, and CDH. In a follow-up email post event, I will send the link to apply for credits. And here's our agenda for our time together over the next 4 hours. Please use the Q&A tool found on the Zoom webinar dashboard to pose questions to me, our moderators, and our panelists. So now our first session to kick off the summit, which is Unleashing AI's Potential, Mayo Clinic's Blueprint for Healthcare Transformation. This session is a one-to-one conversation with Cris Ross, the CIO of the Mayo Clinic, and will be moderated by Shahid Shah, the CEO of NetSpective Communications. And now I'll turn the mic over to Shahid and Cris.
Welcome, everybody. Two of my favorite companies here with the Answers Media Network and Purpose Events, who runs Health Impact Live, have put together this fantastic next few hours. And my job is to basically get this kick-started. We're going to be joined by Cris Ross here shortly to talk about what are the actual impacts that we're seeing with AI in the marketplace today. So if I were to say that AI has been hyped, that would be the understatement of the year, right? So, however, unlike many other, quote, hyped technologies that we have seen in the last few years, it's clear that there is value, and that value is being achieved at a variety of different healthcare institutions. And so Mayo Clinic, everybody knows them. We know that they are the leaders in this area of healthcare in general, clinical specifically. But when Cris joins us here, we're going to be talking a lot about what they've gathered in terms of knowledge that they can share and talk to us about over the next few hours. We'll talk in the next few minutes, but then the rest of the panels will pick up on that. So a few years ago, Cris gave me the opportunity as an engineer. So many of you who know me know that I'm a software engineer, that I've got a lot of experience building healthcare information technologies. And he brought me in over at Mayo, gave me a specific direction, and that was, hey, at Mayo, we want to be the owners and in control completely of our data. And then he asked me to say, okay, let's go work together with the internal staff at Mayo, get the architecture and everything going. So we called this the data unification and data decomposing session from the back end side. So as we all know, AI requires enormous amounts of data, but the one problem that we have in healthcare is that our data happens to be trapped, built in, consolidated, organized, however, whatever words you want to use. Very rarely are the executives who need that data truly in charge, because a lot of that data sits inside other vendor platforms, whether it's an EHR, a practice management system for smaller organizations. It could be an ERP solution for larger healthcare institutions. So at Mayo, what we ended up doing was establish a policy of boundaries that says that the systems of records that maintain these data are no problem. We want to use them. We want to benefit from them. Everyday users are getting enormous value out of everyday systems. But if data remains in those areas, they often remain trapped. And so what we ended up doing was, and this is where hopefully Cris will be able to tell us a little bit about it, more about where we ended up after a few years after the project started, was how much of the data unification has now helped with the AI preparation and the foundational work necessary for AI. So some of the places where we've started discussions with lots of different organizations is, when you're doing AI, are you actually ready with access to your data in a way that you can use it for private training in consolidation with all your other systems. So whenever you embark on a new project, especially an AI-driven one, which is highly data sensitive, you have to know what are our data assets. And so cataloging all those assets, understanding where they come from, understanding what is the streaming, is it coming in every minute, is it coming in every day, what is the retention policy inside the systems of record, all of this becomes hugely important. And this was why that project that we did at Mayo was so awesome, because Cris is one of those few guys who understood that if you're not in control of all of your data, you're not going to be able to put it to new foundational or other uses. So when we started that project and started to elaborate on what that looked like, we had to go and catalog all, where are all the images? Where are all the labs? Where is the financial data? Where is the customer sentiment data? Where is all of this kind of stuff that's already sitting there in different systems? How much was it in the EHR? How much was in your marketing system? How much was in your CRM? Being able to build a 360-degree view of this is almost now seen as a necessity. And so this is something that as you're listening through a lot of these talks and going through the discussions today, ask those questions in the panel. Ask questions here to me and others as we're talking and say, hey, my data is trapped in system ABC. How the heck am I going to use it for AI if my vendor or my partners or my professional services groups can't access that data? So I would really spend a lot of time asking those kinds of questions, like where is the data? How do I get it out? How do I merge it? Because as you all know, the L in LLM is large, right? And so in order for you to be able to take that data, make it useful to AI, that becomes very, very important. So we're seeing Cris is having a little trouble logging in. So while he's joining, I'll tell you a little bit about what we've already discussed. And where Mayo started a lot of their work is exactly where all of us should learn from, and that is administrative automation and financial performance. What Cris has taught us and others in the industry is that when you look at these two areas of administrative automation and financial performance, you don't get trapped into this problem of, do we have compliance? Do we have security? Do we have this? And do we have that? From a medical records perspective, compliance is important, security is important, but whenever you deal with medical records, the conversation just changes. And so where possible, like a lot of the projects that most of us are working on that are diving deep into this area, start with admin, then move to financial. So when we look at what Mayo has been able to do in terms of administrative automation and financial performance, what's really nice is that they are absolutely seeing a lot of value in pure admin automation. And when he's able to connect with us here quickly, we'll be able to ask very specifically on where do we see Mayo's ability to drive financial performance. Like the one thing that very soon, whether it's this month or 3 months from now or 12 months from now, the bloom is going to be off the rose of AI, and people are going to ask us, where is the ROI? Right now, everybody's pretty happy with doing AI as an experiment. They're very happy with saying, all right, we'll try this out. An internal chatbot looks like it's in good shape. But very soon here, there's going to be a requirement for, okay, we spent $100,000. Where's our ROI? We spent $10 million on this. Where's our ROI? We bought a bunch of GPUs. Where's the ROI? As you start to look at that, one of the great areas that you can begin with is financial performance. And so there are now very nice AI efforts on at Mayo and other places where things like, how much do we pay our top doctors? That is now something that AI can help you with. What is the scheduling effort of being able to ensure that there are the fewest number of senior nurses all being jammed into the same place at the same time, so that the senior nurses can be scheduled via different departments, so that the junior nurses can learn from the senior nurses at each skill level and each staff level. Now think about this is, this doesn't require you to have hyper security sensitivity, super compliance, etc. There are daily, day-to-day problems that you're dealing with in things like hiring. How much should we pay somebody? When should we have staff scheduled? When should they be on a Monday afternoon shift versus a Thursday morning shift? As you start to move beyond employees into traditional HR, which is our insurance coverage for all of our nursing staff versus our physician staff adequate? Now, when you look at this, we know that we have tons of departments, tons of people are already there. They're doing great work, but they're all overworked. And so what we're learning from from institutions like Mayo and other large hospitals and health systems is there's a ton of stuff that you can start doing with AI on the HR, financial administration, on the admin automation kinds of areas that we absolutely should start with so that we don't get stuck. Like I've been on now probably a half a dozen projects where people wanted to jump into medical record AI. And as you can imagine, as we moved into the medical records AI space and we started evaluating and saying, okay, like a lot of physicians said, hey, I need the ability for me to have a preparation document when I go see a patient. So preparing for an appointment is a project that I've been working on for a number of weeks now. And it is really hard. Why? Because you have to jump detail into lots and lots of medical records. You have to know what specialty it is. You prepare differently for children versus women versus men. And so what happens very quickly is that the AI experiments become so unwieldy that people are like, oh, this AI thing doesn't work. But it's not that it doesn't work. We just started on the wrong problem. So this is where, guys like Cris can help us teach that if you start with the right problem, get your finance and admin side under control, show some very quick ROI. 2 months, 3 months projects are very easy to do, even in healthcare, right? They're easy to do in other industries because there's not regulation, but even in healthcare, you could do a 30, 60, 90-day effort very quickly, get inside and throw together these kinds of ideas. So if you have some questions, if you have ideas, throw them out in the chat. We'll be happy to talk about it while panelists are up on stage. But the main thing to think about during the day today is, where do I put something in tonight so I can see an impact tomorrow morning? How can I put something in next Monday, not 9 Mondays from now or 25 Mondays from now? And it's a lot easier to answer when we all agree that the financial, administrative, HR, scheduling, credentialing. I mean, that is one of the big learning lessons over the last few months is credentialing and the amount of work that a lot of our credentialers have to do at our hospitals and health systems. We could eliminate on IT side, we could eliminate a lot of work on their side in order to handle this. If you think about legal, the folks who are managing just things like vendor contracts with BAAs, as legal contracts come in, passing them through chatbots, LLMs, machine learning, these are projects that can happen in days and weeks. It does not have to take long to handle at all. So what I want you guys to do is to think about that during the day-to-day impact. What can I do tomorrow that I can use on Friday? What can I use on Monday that I can use by the end of the week? And these don't take a long time if you focus on the right attention. So think about legal, think about HR, think about things that don't require you to get into the muddy waters of the clinical side so that you can get a little experience, you get a little benefit. Everybody believes that AI will be valuable because they've got the immediate benefits. And then when you want to do something difficult, like medical records, like summarizing and understanding, looking at taking the images and putting them in front of cancer boards, speeding up lab result analysis, these kinds of areas do have more work that we have to do. And so it becomes a struggle when you're trying to do something brand new in AI that you have never done in the past. So that's one of the lessons we're all learning is get the paradigm up and running. I see Cris is joining us now. He got the machine problem result. So Chris, as soon as you pop open your camera and get your audio coming, we'll start posing the questions. I've been giving them some really good background on what Mayo has been doing over the last few years in terms of data unification, preparing the data. And so, sorry, it looks like Chris had to pop out. It looks like he's still having a little trouble. So now, as the next piece that we were talking about is, if you start with the most difficult part, which is the clinical records, and you have any problems, you end up accidentally shutting the door to the other areas that people could benefit from. So what I've now seen in the last 6 to 9 months in these AI experiments is, first and foremost, do call the project AI experiments. Don't call it a patient outcomes tool, because you will destroy all your own credibility. What you're running, there are no AI non-experimental projects. Every machine learning project, deep learning, machine learning, neural networks, everything is an experiment initially. Don't even call it a pilot, right? So just start with these kind of experiments and look to say, well, the good news is there are no boards at medium to large scale hospitals, health system practices, et cetera, that have not approved some form of AI review, experimentation, et cetera. So because the board members in your institution have children and grandchildren who are playing with AI, they feel like they know AI enough as well. And if you're on the board of organizations, please approve a $10,000, $50,000, $100,000 AI experimental project, just like Chris and others have done. If you at the top are open, you will approve these kind of projects and things will move forward. However, put a stipulation on it that when you approve the project, approve it for very specific areas that we know will not get curtailed or harmed, because we internally at hospitals, health systems, practices often find it difficult to get consensus on process, security, privacy, et cetera. So when you look at legal, some of that is not a problem. HR, some of that is not a problem. When you look at staff scheduling, some of that is not a problem. When you look at OR, meaning operating room scheduling, some of that is not a problem. When you look at antimicrobial processes to ensure that you're finding out whether you have some superbugs or not in certain areas or not, that can all be done today with large language models, generative AI, in ways that we just could not do 2 years ago. The world has changed dramatically, as we all have known, and definitely more have seen. But in one way, it has not changed, and that is the business wants to know, after it's spent a few $100,000, what do we do? So once that happens, then the board comes asking, hey, where's my ROI? Welcome, Chris. I know it says Megan, your name is Megan, but of course you're Cris Ross. Chris, great to see you. Sorry you had a little bit of trouble getting in, but I've brought everybody up to speed a little bit on how you brought me in a few years ago to help with kind of data unification, decoupling the data from systems of records. So tell us a little bit about your recent journey at Mayo. Where did you start with your decision making about AI, and kind of like where are you seeing the most impact at this time?
So Shahid and friends, first, apologies for getting connected. All the links just weren't working for me this morning, but here I am, and I get to be with Shahid, who's a little bit of the I don't know, godfather or initiator of some of our journey. As you said, we've tried to do a lot of work to unlink our data from transactional systems for a bunch of reasons. The other thing that we tried very hard to do early days was to figure out how to take data out of silos and put it into combined registries. We had lots of registries. We had radiology registries. We had nephrology registries. But the goal was to try to come up with what we now call multimodal data, right? Images, text, structured data, and all the rest. And a lot of that was driven by our innovators who were already building data sources, who were already replicating each other's work. So we made a big institutional investment to begin to bring that data together in 2014. Again, Shahid came and consulted with us. I remember being in this really weird conference room at a sort of rented space halfway between Rochester, which is the main place for Mayo Clinic, and Minneapolis, St. Paul, and we bashed some stuff out. So that's been a little bit of the rocket fuel for what we've been working on.
Yeah, and speaking of that as rocket fuel, provide some maybe color around the idea. What happens at organizations if all of their data is still currently sitting in systems of record and they did not do the both fortuitous and then well-planned effort of decoupling their data? What should they do now to try to get some of that data out of those systems of records?
Yeah. So at least in the clinical space, if we're talking about provider space, the EHR vendors are doing a pretty good job of creating some unstructured data repositories to do a variety of things, whether it's, Cerner, Epic, and to some degree, Meditech. Those organizations, whether they adopt an EHR resident data-centric tool or not, or if they're building their own, the movement has to be to find a way to consolidate data, to govern data, to get away from traditional data warehouses into models that support non-SQL kind of structuring of data, to think hard about metadata and the governance thereof, find a place to get started and accelerate. I think if we had come to Mayo and said it would cost X for us to build the data repository that we're operating on today, we would have never gotten off the ground. Mm-hmm. So instead, we focused on how could we get to some achievable goals. So step one, I think, would be to just find which repository you're going to use or what approach you're going to use and go for it. It's the EHR space, or the alternative to some degree is, there are tools out there and there are vendors out there that will create data lakes for you. We sort of bypassed that and went all the way to the source. Our choice really came down to Google versus Microsoft. Both are perfectly valid choices. Both have data engines that are bound to structures like FHIR. Amazon is really impressive. Their engagement and commitment to creating healthcare data models is not the same as Google or Microsoft. So I think it's really what's your target going to be, and what's the place that you can get started on. I heard you talking about ROI as I joined. What generates ROI right away?
Yeah, perfect. And that's a great transition and there was a question by Anita asking, what role does FHIR play at in Mayo Clinic AI? Do you have like a quick 10-second response to that? And then we'll
we've got two schools of thought at Mayo, one of which is we want to access the data in FHIR format, and the other is we want to access it in OMOP format. And I think this is going to be one of those religious debates. OMOP has certain advantages that researchers like. FHIR is absolutely the model to use in runtime. Once there is an algorithm built, the algorithm ought to consume and use FHIR-bound data because it's become lingua franca in the transactional world, at least in the provider space.
Yeah, and for Anita, the way I would say is adding on to Chris's comment is it's got to be a yes and. Like, this is one problem with AI and data is you can't just say I'm going to have it in one format or another. That's the multimodal lesson that Cris is teaching us. And there you have to say FHIR and HL7v2 and that's the only way that we can do anything real in the difficult practical world that we live in. Yep. So that having been said, Cris, if we start with, so one discussion that I've been having at a number of different institutions is, where do you begin the AI journey? And so if we think about legal, HR, staff scheduling, OR scheduling, admin automation, where did you guys start? If you just talk non-clinical for a second, where could people start pretty easily at their institutions?
Yeah, so the first question is build, buy, or partner to some degree. And, some places are committed to doing some build work. I can come back to that. But I think for most institutions and for us, buy is a huge component of it. So it's really what is available. So I think most institutions have been using computer-assisted coding for a long time, and those systems are increasingly more AI-assisted coding. We've been doing a lot of work around how to reduce administrative load on clinical staff. One of the biggest challenges all of us have is shortage of clinical staff, especially nursing. So what can we do to do things like inbox answering or summarization of visits for patient purposes or for documentation? In the purely administrative space, I think there's a lot of things that are still in the kind of invention mode. We've been using Copilot a lot. We have people who've been experimenting with Gemini. I think the one thing that was a real killer app for us was transcription of meetings and then summarization of meetings using Copilot. I see it everywhere in our institution. Everybody turns on the transcription button. Everybody hits the summary at the end, and it gets you 2/3 of the way towards having minutes for the meeting. Sounds trivial, but it means minutes get turned around more quickly, which actually helps us move a little bit faster because we're a really committee-run place. And it takes away time of people taking notes during meeting. They can pay attention. So, I think voice-based stuff, whether it's clinical or administrative, I think we will look back as sort of that killer app that initially emerged in the generative space. Does that make sense?
Absolutely. And where have you found any pushback? For example, if there's a meeting in which you're talking about patients, have you gotten pushback to say, well, we can't transcribe this because it's not going into the right repositories, or has that not been a problem?
Part of the way great question. Part of the way that we've avoided that challenge is that any voice vendor we work with, we have a very strong business associate agreement that includes an information security agreement. So we're comfortable that when voice is being used, that the engines on which it's operate within a legal framework that we're happy with. And we know that our data is not being harvested. We have had vendors who want to use our voice data and other data to train their models. We're not completely allergic to that, but it needs to be under a very, very strong framework.
Yeah, it makes sense. And there's another question on the screen here. What are the best educational resources that you recommend to learn more about health AI, if any, books or sites or blogs?
So the places that I think, there's lots of places where you can get started. The places where I think we've gotten really big acceleration are things like Hugging Face site that lets you know what's going on right now. The various blogs that are maintained by the hyperscalers. So the Google, Meta, Microsoft, Amazon blogs are all super great. I rely a lot on a really cool newsfeed website called TLDR, too long, didn't read. That gives me the gist of an awful lot of things I want to get into. But honestly, you can dive into, I'm most fluent with the Google sites because we're a Google partner.
Yeah.
And we do a lot of work with them. You can go as deep as you want in their blogs. They're all giving away the engineering right now. I mean, it's just out in the open.
Yeah, and so one quick note for the questioner there is a lot of material available now, both healthcare specific and non-healthcare specific. One thing you want to try to do is to not go too far down the rabbit hole on the healthcare specific side, because almost all the foundational models that we see in the marketplace at the moment are not healthcare specific, which means that you have to get your requirements correctly mapped to those foundational models. Has the question of foundational models come up at Mayo, maybe building your own foundational model, or you guys are pretty happy with the models that are out in the marketplace at the moment?
So it's both. We've done some announcements about some foundational work we've been doing with various partners. I think, if we go back 14 months, 15 months ago, 5, 6 months after OpenAI released the original GPT tools that at least were in common parlance, I think there was maybe a lot more enthusiasm about model creation. I happened to spend a couple of hours 2 weeks ago with Peter Lee from Microsoft, who's one of the great geniuses in space. By the way, read his book if you want to know about application of AI to healthcare. I'm serious. Zach Cohane, Peter Lee. It's got a general name. You can find it on Barnes & Noble, Amazon, wherever you want to find it. He was telling me that on Hugging Face, there's something like 22 new foundational models being listed every month. I think the world is pretty well hydrated with foundational models. The issue is going to be somewhat in scaling. Like, look at what, rather than domain. If you look at what Google's done with Gemini, right? They have sort of macro models down to micro models that can actually run in an untethered way on an Android device. That has to be a pretty small foundational model. We're going to do some work because Mayo has the resources to be able to do it that many people don't. We're privileged in that position, but frankly, even we are going to leave most of the foundational work to the hyperscalers.
Yeah, and that's really the key lesson, and this is the lesson you taught us back in 2014 when you started the project, is focus on the data, not necessarily on the model right now. So just get all of your attention on, can you get access to your data, and you will work out everything else in time because lots of solution providers are out there. So as you start to look at the admin and the non-medical work, cyber comes up quite often. What are you guys doing on the cyber side with AI, if anything?
So, the use of AI is fraught with dangers. It is release of data inadvertently. I always try and make a distinguishment between privacy and security, and I'll talk about that in a minute. And then the other issue is really around bias and drift and maintenance and all of the other sort of moral hazards that come with asking a machine to think. Specifically with respect to cyber, again, probably the first place is we put in place a strong governance process around third-party risk management. And I will admit it drives our innovators crazy from time to time because they want to have unfettered movement. I get it. But we can't work with absolutely every single party who comes along. A small startup, you know what? They sign your business associate agreement without blinking their eye. And that worries me because that means they're not paying attention to it. Or it doesn't matter because they're in startup mode and it's, fail fast. Well, not on our dime. So having a strong, well-understood BAA and ISA is a really big deal. After that point, the issue around, does AI include any more opportunities for hostile party intrusion? And to be quite honest, I don't think that we have found too many unique instances where that's an issue. We have questions about privacy for sure, like how long do we keep transcription of conversations that might have clinical or business confidential content on it? And we adjust that all the time. But specifically, the kind of attacks that exist, in particular the ransomware attacks that are 90% of the problem right now, AI does not seem to uniquely introduce pure adversary attack modes. I'm sure there's a CISO here who's tearing his hair out and saying, what's this guy talking about? He's crazy. But there's not many mainstream, top of our list concerns that we have that we aren't addressing with respect to every other technology in our portfolio. Does that make sense?
Yeah.
Privacy, totally different question. Privacy is a different issue. Lots of ways we can inadvertently release data. We have to be hyper vigilant too.
That's right. And for just for the general audience, because there are so many people on listening in, what you want to make sure is that if your privacy or security folks do jump in with issues, and they should, you have to be asking them to give you real scenarios, not pretend, not what might happen, because the benefit of the AI project is so high that you have to be able to get something started, because you're going to lose time and lose actual benefits when I love it when a CIO, especially of Chris's stature, says, there are probably lots of problems, but nothing that we can see right now. But if we see something on Friday, we'll address it, right?
Of course.
That is your best case scenario.
Of
So
course.
does that seem like a reasonable approach for everybody to take?
I would think so. Yeah, I mean, we align ourselves to the NIST standards pretty strongly for how we do cybersecurity. We attach to other standards as well, and we try and meet all of them. It's impossible for everyone to be 100% safe in every respect. Adversaries are going to do bad things to us. The one that we know of in the kind of normal space is everything around email-based phishing attacks that get people to bad sites or to give up credentials. There's increasingly more social engineering, phishing kinds of attacks, and so on, to get people to give up credentials. That's where the attacks are coming from, primarily. People are not using as much brute force because most people have closed up most obvious backdoors.
Yeah.
Your mileage may vary. I want to acknowledge the point of your question, though. As we advance AI technologies, they're going to bring in stuff that will create new vulnerabilities that bad actors will exploit. We try and stay vigilant for them. But, our guidance is coming from, what's in the open source for the most part, the government-based best practice standards.
Yeah, no, and I think that's a great strategy because until we do it, we're not going to learn. And if we don't learn, we're not going to be able to protect. So with that, we only have a few minutes left in the rest of our session. So take us home with this question. The vision question is, you now have a lot of benefits locally that you've gotten through admin and financial performance, et cetera. What about the clinical side? Obviously, Mayo Clinic is the clinical institution in the world. So what do you see as the next 12, 18, 24 months, maybe not 5 years, but just the next couple of years? What are some really cool things that you think might transform clinical care?
Yeah, thanks. We admire lots of people in the industry who are doing really great stuff. I'll give examples from where we are. Some really early work has been around cardiology and the detection of arrhythmia. We published a lot of materials in Nature about 3 years ago about the ability of AI to discern arrhythmia in patients that have normal rhythm. And it turns out that machines can distinguish populations. Because of that, we can get to the point of where a consumer grade, Apple Watch type device can in fact detect arrhythmia, either the onset of disease or an instance for someone who knows that they're susceptible and they can take action on that. We think that's really going to be important. There's lots of ways in which we're doing some augmented practice in areas that relate to voice. So how do we do, passive listening and other things? That's in the mainstream. Everybody knows about those. But I think that they're going to be truly transformational. Whether we are going to get to diagnostics, I don't know. We'll probably get there. I gave you an example about cardiology, but the phrase is now trite that AI is not going to replace doctors, but doctors who use AI are going to replace doctors who don't use AI. I think that's absolutely true. So we're doing a really cool thing right now around chatbots that we think will help people see things or move more quickly in ways that we can give more treatment, more hope, more healing. And it's really fairly simple things like, rather than having to open up the entire EHR record and search for something in a way that might be cumbersome, how do you ask a question? What's the smoking status of this patient? Please give me a summary of the surgeries that this patient has had. That chatbot is an early rollout in our environment, but it's super exciting as a way of just creating more velocity for our physicians. Imaging work, there's a lot of things that are being done in radiology. Right now we have detectors that will highlight pulmonary embolism. Like many, we're doing some work around doing an automated chest X-ray read. CTs are different, but X-ray reads are something that we can potentially actually generate a report directly out of the image and the medical record itself. So, my hope is medical practice will be easier in that it will reduce a bunch of documentation and the kind of clicks and navigation that people don't like. What's behind all that clicks and navigation is a whole set of rules that we put in place to keep patients safe and to move people more quickly. And people may not understand that 2 extra clicks or 3 extra clicks actually is reducing another form of work. But now we need to find a way to reduce both. So, maybe we're going to get doctors who can discern a little bit better. But honestly, I think 3 years from now, the use cases that are going to be the most compelling is not a doctor who's been now displaced, but around doctors who say, oh, my work is easier. I can see more patients and not feel like I'm stressed. My after work has been reduced. When I need a prompt, when I want to get to some tool that's going to help me, if I want to look up the latest medications, it's just at my fingertips and it feels easier. I'm going to talk more and I'm going to type less and I'm going to click less. If we're successful, my opinion is that's where we're going to be in 3 years and probably 5 years beyond that. Machines doing diagnostics, don't know. That might be icing on the cake.
Yeah, no, this is fantastic, Cris. I really appreciate your time, and we're going to hand it over to our next panelist here. But the main lesson that you guys all heard as one of the top CIOs in the world and a top institution is AI is here, real impact right now. Don't be afraid, right? Get started.
Yeah.
There's a lot of ways and a lot of help that's out there. So I think that's the big lesson is don't wait. So with that, Carol and team, I'd like to turn it over to you guys for the next panel.
Thank you.
Thank you so much, Cris.
Thanks,
you so much,
Shahid. Always
Cris.
great to be with you, my friend.
Thank you very much. You guys are wonderful. Thanks. All right. So let me just go back to my PowerPoint as we move along. We are running, of course, a little bit behind, but we will catch up. We had scheduled 10 minutes for break time anyway, so we will get there. So